Thank you. Ki Nixikoa, Nutaniko, Dr. Jason Deen. I use he, him pronouns, speaking to you from Coast Salish land. And thank you for the invitation to talk about the Indian health pathway. This serves as a primer for Indigenous health for our medical students at the University of Washington School of Medicine, but it really is a national model for what a Native health or Indigenous health curriculum can look like for major academic centers, particularly at your academic center, which has a very high percentage of patients who are Indigenous. So I don't have any disclosures. So this is kind of the outline. We're gonna go through. We're gonna set the stage with some historical context, and what I'll do is I'll summarize, hopefully not very long-windedly, healthcare delivery from the United States federal government to Indigenous nations in this country. We'll touch very briefly on American and Alaska Native health inequities. We'll introduce the concept of decolonizing medicine, which is a framework to try to address some of these health inequities. But really the kicker is the last point, and we'll think about how to augment the number of Indigenous physicians and how to train allies to take care of Indigenous communities. So this last point definitely is more salient to academic leaders and academic physicians. So we'll start out with the historical context. So Native peoples in this land really have a very complex relationship with the United States. I just want to remind everyone that this country was built on genocide and on the backs of slaves, and that has set the stage for multiple systemic barriers to Black and Brown people in this country to have success and lead healthful lives. So due to this complex relationship, there's been an intricate constellation of federal Indian policy, treaties, and other intergovernmental relations from the federal government to some of these tribal nations governments, and it was detailed early on that certain services should be provided to Native people, and these services were guaranteed through a series of treaties, which unfortunately were not honored. They have been dictated through executive orders and other laws, and we'll just kind of go through what are the more important Indian health legislation laws that have been passed for the past in the past century. So this results in a trust relationship on behalf of the U.S. federal government to provide services to American and Alaska Native people. Naturally, a lot of these treaties were not honored. So this sets up a very long-standing history of mistrust between Native peoples and the federal government. And that mistrust, for what it's worth, is also applied to the medical system, because in general, the medical system has left lots of Black and Brown communities behind in our country. So the first important act was from about 100 years ago, and it was called the Snyder Act. And this really designated the Bureau of Indian Affairs under the supervision of the Secretary of the Interior. And what it said that the BIA really shall direct, supervise, and expend monies from Congress from time to time as appropriate. So it set up appropriations funding for the benefit, care, and assistance of the Indians throughout the United States. So an important act for sure. It definitely designated monies, but set up a system where these monies would need to be continually appropriated by Congress. The next was called the Transfer Act in 1954. And what this did was it shifted Indian health expenditures from the Secretary of the Interior to the Public Health Service. So what it said that all functions, responsibilities, authorities, and duties related to the maintenance and operation of hospital and health facilities for Indians and the conservation of Indian health shall be administered by the Surgeon General of the U.S. Public Health Service. So that was important because it really centered the native health issues to folks that thought about them more in depthly. It further said that whenever the healthcare needs of Indians can be better met, the secretary is authorized in their discretion to enter into contracts which provided the transfer of Indian hospitals or healthcare facilities unless such action has been approved by the governing body of the tribe. So the important point for this is that this gave the tribes some tribal sovereignty, some ownership over their own healthcare decisions, and started a snowball to eventually the tribes being able to apply for their own funds. The Indian Self-Determination Educational Assistance Act of 1945 established carryover funding, so those funds that weren't used from the prior appropriation cycle could be used for the subsequent one. It allowed third-party revenue, so now tribes could ask for monies from other institutions and other entities without affecting the amount of monies that they got from the federal government. It also allowed the tribes to apply for grants, and this set up what's called this Tribal 638 program, which is a wildly important program now that allows tribes and tribal healthcare facilities to apply for grants for their healthcare dollars. And it noted that the eligibility for the grants, they weren't the federal agencies specifically involved with the Indian Health Service were ineligible of these things. And it also allowed contract support costs. So, once these tribes got these monies, they could work towards sustaining those funding streams. A year later, the Indian Healthcare Improvement Act, which was really the landmark law which organized healthcare delivery to Indigenous folks in this country. It really helped set the stage for national policy. It established the urban Indian health programs. About half the natives in this country live in rural areas, and about half live in urban areas. So the urban Indians really had a deficit in regards to what sort of healthcare facilities that they were allowed to access. It really allowed the Indian Health Service and other tribal 638 programs to build Medicare and Medicaid, which again formalized some payments on funding streams. So currently there is a 3-tiered system for healthcare delivery for the majority of American Indians and Alaska Natives in this country. And it's called the ITU system. So there's a federal system. Again, this is governed by the Public Health Service. There is an IHS director that directs federal monies from congressional appropriations to specific federal Indian Health Service sites. There's also a tribal system, as I kind of mentioned, and these are tribal clinics that may apply for certain grants. They may use their own internal funds, such as gaming funds, to forward their own healthcare initiatives. And then there's currently 34 urban Indian healthcare programs nationally, making up the urban health centers. Seattle has one of the premier ones in the Seattle Indian Health Board, which houses a family medicine residency as well. This is the map of the U.S. broken up by Indian Health Service site. New Mexico is in the Albuquerque IHS site. I am in the Portland IHS site. Note that Navajo, since it's the most populous tribe in the country, has its own Indian Health Service site. So the Indian Health Service really is chronically underfunded. So we can, it's another big lecture to discuss whether and to what extent that has contributed to some of the health inequities that we see in Native populations. But these data are pretty stark, I would say. So these are Indian health expenditures per capita compared to other federal health programs. And these data were from about 10 years ago. So you note that Medicare is the best funded federal healthcare program. So each Medicare recipient receives about $11,000 per year. Veterans naturally need to be cared for. So the veterans and the VA programs allow veterans to access approximately $7,000 per year. So we have to look all the way down to the end of the scale to see the Indian Health Service expenditures. And folks who are plugged into the Indian Health Service really get around $3,000 per year. And again, and we're going to talk about this in a second, American Indian Alaska Natives have among the highest prevalence of health inequities. So this amount of funding is definitely lacking, I would say. So thankfully, we have those other systems of care. So we're going to shift a little bit and talk about American Indian Alaska Native healthcare inequities. These inequities really have persisted since contact. So they've persisted for over 500 years. And they're really influenced by several things, but I think that most likely that they're influenced by colonization and economic and political interests. Now, those economic and political interests really dictate the reason for these health inequities that we see, and unfortunately, they dictate the responses to them. So think about that for a second. I mean, that's a kind of double-edged sword for the Native folks in this country. So we see these in Indian Health Service data. This is infant mortality. I would ignore the unadjusted rate, which didn't take into account racial subtleties in racial categorization. So I would look at the adjusted infant mortality. So naturally, unfortunately, the adjusted infant mortality rate for American Indians, Alaska Natives in 2007, 2009 really far outpaced all other U.S. races and definitely U.S. whites. So these are data from around the same time from the Indian Health Service, and notes that across the board for almost all causes of death, American Indians and Alaska Natives had exaggerated incident events. So the first column is the American Indian Alaska Native rate. The second column is compared to all U.S. races, and then the ratio of these here. But you can just kind of look down the list. So American Indian Alaska Natives have more cardiovascular disease. They have more accidents from unintentional injuries. We all know that diabetes and alcoholism are prevalent in Native communities. COPD, cerebral vascular disease, chronic liver disease, and cyanosis. I mean, you can really kind of go down the list and note that, we have a problem here. This was really laid bare with the COVID-19 pandemic. We've those of us who work in Indian health, care for Native patients, really knew that these things were kind of percolating under the surface, but these things really reared their head during the pandemic. So, due to the high prevalence of comorbidities, sometimes the lack of consistent care, sometimes lack of access to care, American and Alaska Native communities were at the highest risk for exaggerated mortality and morbidity. And the Navajo Nation was really a case study for this, because the Navajo Nation during the early pandemic was the most affected of any community in the United States per capita. So there were more than 5,200 cases of COVID-19 with 241 deaths in the setting of a population of about 173,000. And this is due to a variety of different reasons, and these are just some of those. So limited communication. So some of these families, some of these communities were unable to get information about the COVID-19 pandemic and how to prevent it. For example, only 40% on the Navajo Nation have internet service. Only 30% of folks on the Navajo Nation really lack clean running water. So naturally, hand washing would have been problematic. An equal number did not have electricity. It's very common in especially rural Native America that multi-generations live under a single roof, which again, really complicated things. So say a child contracted COVID-19 and that was easily passed to elders who may have those comorbidities. And then there was just, again, fewer resources for these communities. Overlaid on that is, as far as etiology for these chronic disease disparities in general, is the effects of living in the U.S., the effects of longstanding genocide, the effects of things like boarding school experiences and toxic stress. And what this really set up was this intergenerational transmission of increased chronic disease risk for Indigenous folks in this country. So these were due to chronic inflammation, epigenetic phenomenon, changing underlying DNA, and these elevated risk factors were passed on from generation to generation. So we say that some of of our grandparents had lots of historical trauma. They were told stories about the genocide that was experienced by their families. They were placed into boarding schools for assimilation purposes, where they were exposed to abuse, neglect, abandonment, forced removal from their communities, a loss of their culture and language, and they were forced into systems of Christianity. And it really perpetuated this loss of traditional parenting skills, and it disrupted family structure. Now that in turn leads to adverse childhood experiences, so various forms of abuse, neglect, those sorts of things, and all of these add up to an increased lifetime risk of chronic disease states. So yes, there are behavioral things that may be the cause of these health inequities, but really this has been set up as I kind of mentioned before, from a long standing system of systemic racism towards American Indians and Alaska Natives. All right. So decolonizing medicine is a relatively new concept, I would say. And this may be a framework for those of you seeking to provide more equitable care to your Black and Brown community. So it's just an example of this. You can use this to frame things like your healthcare delivery, community engagement, focus on public health, and maybe the use of inclusive language. And I always like to tell this one story about the Seattle Indian Health Board, which I think they do something small, but something very powerful in regards to decolonizing the way they give healthcare delivery to their patients. They actually don't call their patients. They call them relatives. So they say, we have a 36-year-old male relative with tobaccoism and COPD, right? So, I mean, can you imagine the effect that has on some of these communities, to be referred to not as a patient, but be referred to as a family member, and then the effects on not only the faculty and staff there, but the trainees through the Seattle Indian Health Board. They have this notion, immediately upon walking in, that these folks should be treated just like your own personal family members, your mother, your father, your uncles and aunties, your children. So this is a small way that the Seattle Indian Health Board is trying to get at maybe decreasing some of that mistrust that a lot of Native folks have towards the medical system, using inclusive language like that. It's a very small but powerful way, example of this, of decolonizing medicine. But if we look at the framework of decolonizing medicine in general, it's important to remember that systems of medicine and healthcare delivery existed really before contact, and that colonization really changed a lot about how healthcare was delivered to Americans, and it's influenced our health systems, and unfortunately, it has influenced healthcare outcomes globally. So, if you, consider this as an example of more equitable healthcare delivery, we can arrive at considerations towards trying to remember what healthcare delivery was like before the importance of treatment, before the importance of p-values, for say. So this approach was very inclusive, and it really empowered the voice of those whose healthcare was most at stake. So colonial medicine in general was a definite and immediate shift from indigenous methods. Suddenly, healthcare delivery was really defined by the absence of disease rather than the promotion of health, and thus there were specific methods developed to attack specific diseases, right? So in my day, as a mid-career academic person now, I learned the importance of invasive surgeries, novel treatments, and the importance of that p-value, right? So this notion to approaching disease as a focus really appears to be cheaper. Currently still appears to be cheaper and more manageable, because of all the healthcare expenditures focused on treatment rather than public health and primary care. And what they thought was that this method was really better than trying to improve health through other means that may have been, more indigenous, such as social and economic development, community health, supporting the community itself. So colonial medicine also viewed broader-based efforts to deal with underlying economic and social determinants of illness as really impractical and unnecessary. So really ignoring the pipeline for some of these things and just kind of treating things at the back end, the antithesis of the general principles of public health, I would say. And that was just a general disapproval of traditional medicines, which were commonly used by indigenous folks in this country. Now, the healthcare systems before colonization, those used by the indigenous folks of this nation, really are in a global healing tradition. And in general, if you look at a lot of ancient healing traditions across the world, and again, there are indigenous peoples in every continent, they are in general holistic and earth-based. They value community health over individual health. So they really include both generational and community involvement in regards to health initiatives and in regards to teachings. They're really, really valuable to those who practice these traditions, which are the folks who naturally would benefit most from the practice. So these traditions in this country were really disrupted by colonization, and the health of those who lost those health systems really have been affected now and continue to be affected. I think that you could extrapolate this to all Black and brown communities in this country. So there is a great benefit from just the notion of decolonizing, just the notion of remembering that maybe we spend too much on healthcare dollars. Maybe we need to focus on primary prevention, primary care, public health, and those sorts of things. There is an idea about indigenizing. I'll come up with that. There is an idea about indigenizing health systems, and we'll kind of talk about that in a second. And again, the Indian Health Pathway in general is a method to provide this notion to our current medical students. So decolonizing of just health systems in general really has a variety of different evolving definitions, and it really depends on a certain person's varying history or of population. So you could extrapolate this to Black and African American communities. You can extrapolate this to immigrant communities. Really, it requires kind of raising awareness of the underlying social issues that some of these at-risk communities are facing. And it's really intersectional interdependence. So really, again, getting away from that individual kind of healthcare delivery system and trying to approach a community in general. We really need to realize, and I think we all do, the feeling has shifted that lots of healthcare issues and healthcare disparities that we see are informed by social determinants of health and systemic racism. So I think that that is a general notion that has general assent with a lot of academic institutions. It's important to know that individuals and institutions reinforce constructs that perpetuate these systems. How many Black and brown leaders do we have at our academic institutions? Do they really understand where those of us who come from these communities, where we come from, where their patients come from, if they don't look like them? So I mean, it's a perpetual thing. It sometimes requires individualized approach for certain systems and communities. I would say that there are, over 570 federally recognized tribes in this country. There are over 270 non-federally recognized tribes. So if you're looking at Indigenous healthcare delivery, there are therefore over 800 different ways of doing things. So that said, that this notion of decolonizing for all Indigenous folks is more of a pan-Indian plan, I would say. So what does decolonizing medicine really mean? It's really recognizing that systems that would help those at-risk communities are currently in place, and they really focus on things like economic development, education, social determinants, political voice and power. It's important to recognize also that Indigenous systems have really existed historically, and they do currently coexist. I'll go back to the Seattle Indian Health Board again. They have an allopathic department, which houses the residency, but they also have a traditional Indian medicine department, and those two departments care for their own patients naturally, but then may cross consult each other at appropriate times. So that is a very, very important system. It really restores that Indigenous worldview, focus on family, focus on community, focus on public health. It would restore certain cultural and traditional ways depending on a specific area or a tribe. It includes Indigenous perspectives of history and practices, which has been a struggle given the lack of, if we're thinking in the context of academic medicine, struggle because of the very low representation of Indigenous folks in academic medicine. And it really requires, and this is what you should kind of take from this, really requires communication. It requires belonging. So it's not us telling some of these, under resource communities that this is what you should do, but it's really community engagement and trying to really delve into some of the nuances of what these communities are exposed to, what these communities are, what their goals are, and trying to help them manifest their own goals. So there is a in Indigenous health professional circles an idea, a little seed for indigenizing medicine in general. And this really needs to focus on inclusion of Indigenous voice and cultural perspectives. And programs are currently developing in this way. There are thoughts to have Indigenous health as an academic discipline. There are thoughts to have Indigenous medicine as a clinical science. There are thoughts that Indigenous health professionals really need leadership development. And there is, in general, a need to establish an Indigenous school of health sciences. I will say there's a couple places in the country that have taken a big step forward in this last regard. There's an osteopathic school, and osteopathic medicine is really, OMM, the manipulation part of things, is really grounded in some early Indigenous practices. But there's an osteopathic school associated with the Yakima Nation here in Washington State, and there's an osteopathic school associated with the Cherokee Nation in Tulsa, Oklahoma. This is again, this is a little flicker, I would say. We really need to feed this idea in my own personal professional groups in order to build into a brighter, warmer flame. There's lots of systemic barriers to this, however. For instance, as I kind of mentioned, and we'll talk about this in a little bit too, there aren't that many natives in academic medicine. So as an example, take full professors. Based on some recent data, there are about 37,000 full professors at across the United States in academic centers, and only 37 of those people, so literally 1 in 1,000, are Indigenous. So again, how do we get to that? Well, what we do is we try to augment the number of Indigenous physicians, and it's going to take a while for us to come to this idea, this ideal of us being able to care for our own folks, of us being able to train our own doctors and those sorts of things. So in the meantime, we really have to train allies to best care for some of these communities. So why is this needed? The pathway into medicine for American and Alaska Natives, I know JP thinks about this way more than I do, but the pathway has a lot of barriers for lots of Black and brown communities. So these are just some relatively recent AAMC data. I know that this bar graph is a little fuzzy, so I apologize about that. So what it is this shows, again, these are AAMC data. This shows American and Alaska Native applicants in the blue bars, actual matriculants to medical schools in the gold bars, and then those who graduated from medical school in the red bars. So these data are from 1978 down to 2002. You note that in general, the amount of graduates have been right around 100 most recently. There was a bit of a boom in the 90s, and I was the product of some of these programming, but there was a bit of a boom in the 90s when HRSA funded Center of Excellence, Native American Center of Excellence centers in major academic institutions. I know that New Mexico was right up there. The institution I went through medical school at, the University of Minnesota, was in there. The University of Washington, my current institution, was in there. So if we compare, hey, there were 50 medical students in the 70s and now 100 in the in more recent times, it's still not enough. And this has trickled down to the amount of active physicians and full-time faculty that we see now. So only about 0.5% of current U.S. physicians identify as Indigenous. And it's less than 0.5% if we look at academic faculty. So these are really challenging things to look at. So many academic institutions in this country are working to attenuate these problems, attenuate these inequities that we see. Here at the University of Washington School of Medicine, we have several pathway programs that are focused on not only natives, but all Black and brown communities and underrepresented medicine communities, including South Asians. And we target kids really early in their elementary school ages. We have a Doctor for a Day program. We have and these monthly meetings are geared towards there's general meetings, and then there's ones that are geared towards affinity groups. So say they take kids from local tribal schools, and then we leverage the Native faculty here at the University of Washington to be the facilitators of the program for the day. We have something called the Community Health Professionals Academy, and this is co-led with the School of Dentistry, and it really approaches, it's a Saturday program for elementary and high school students, and it just exposes them to health professional careers. We're a site for SHPP, the Summer Health Professional Education Program, which targets undergraduate students, Black and Brown undergraduate students. The University of Washington also has a pre-admissions workshop called UPrep. And then for specific Native health program, we collaborate with Oregon Health Sciences University for a Native specific pre-admissions workshop. And these things are wildly important. My own story is that my mother's Native, my father is an immigrant from South America. Neither went to college, and I had really no mentorship. I went through, I got scholarships to parochial schools, but still I had a lot of barriers in there. And I was thinking, every time I get a funding request from my high school, I think about the fact that I don't think I ever really met with a high school counselor, despite having a 4.0 grade point average. I can't remember meeting with one of those folks. So, even coming out of a parochial school for me, I didn't know how to take an SAT. I didn't even know what the SAT was. I showed up and took the test, and I applied to all the colleges around my house because what else was I going to do? So this story, I couldn't even think about medical school at that time. Well, I couldn't afford to even apply when I was a college student. And this story is common when it's probably common among you all. It's definitely common among these kids in some of our communities. So these early touch points are vital to, just so these kids can really see someone who looks like them in these positions of power. They can realize what they are capable of, and then they can get some mentorship. Through my office, we mentor all Native pre-medical students, I would say, keep track of them, bring them to our houses, and just try to help them out as best we can. So again, very, very important. So switching to the IHP. So the IHP, it prepares both Native and non-Native medical students for careers in Indigenous health. We also encourage research in Indigenous communities, and we mentor them through those experiences. And it really enhances the curriculum on American Indian Alaska Native health issues at the School of Medicine. University of Washington School of Medicine is the main medical center and the main medical school for a fifth of the U.S. landmass. So Washington, Wyoming, Alaska, Montana, and Idaho, so the WWAMI region. So we have a lot of Native folks who filter into our health programs. It really provides a unique educational experience for medical students to learn how to provide culturally proficient culturally humble care. I should change that. Care for American and Alaska Native patients. And we have been successful only because we've been able to utilize Indigenous academic faculty at our own institution, as well as community leaders who are focused on healthcare issues. And we provide this collective experience to these learners for what it means to, do research and do Native health research, what it means to be a Commissioned Corps Indian Health Service provider, what it means to work in a tribal clinic, what it means to run an elders group focused on, regaining some traditional means. This is Dr. Joey Nelson. He's literally the poster child for this. He's from the Yakama Nation. He's a brilliant person. He's currently the chief resident for family medicine at the University of Washington, and we are heavily recruiting him to stay. But in general, the Indian Health Pathways was established 30 years ago, so it's been around for 30 years. It was established by the first American Indian graduate, Dr. Walt Hollow, from the School of Medicine. We've had over 105 graduates of the program. And most of those graduates were Native. This is the general curriculum that we expose them to. There's an Indian health issues class, and we'll look at some of the goals for that class. There's a community engagement project, again, trying to get to that notion, that decolonized notion that community health really trumps individual health, I would say. Since I'm a health inequities researcher myself, I have really encouraged folks to do scholarly work on a cooperatively approved Indigenous health topic. And these have been very, very intricate projects from some of these talented students. I have a mentee who just abstracted data looking at neurocognitive outcomes for American Indian elders taking opioids. There's also a group of Alaska Native women who are current students up at our Alaska site who are, interested in pediatrics. So they're focused on pathway programs. So what they've been doing is they've been going into tribal schools and trying to expose students to health professional careers, to medicine, in a very kind of rigorous way, using quality improvement metrics. So there's also a traditional Indian medicine clerkship, and this gets to the idea that, that Indian health is intersectional. I would say this gives the students a notion that, the patient that you may be seeing in your exam room may be using you as a secondary form of healthcare. It is not, using an allopathic system as their primary form of healthcare. They may be using their own traditional healers. They may be using plant medicine. They may be really mistrustful of the usual kind of allopathic system. We teach students to do a spiritual assessment as well during this clerkship. Which is basically approaching someone in a very culturally humble way and really asking, are there other traditional means or methods that you're using? Do you see a traditional healer along with seeing me? Those sorts of things. And then they do an Indian health clerkship, and this is defined as primary care as defined by the Indian Health Service. So that's pediatrics, family med, medicine, med peds, psychiatry, or OBGYN. And these are experiences throughout the WWAMI region, hanging out with docs who have their careers based in Indian health. These are some of the goals of our Indian health issues class. We want the students to understand historical background of federal policy towards Natives in this country, really emphasizing health issues with that progression. We kind of talked about some of that in the beginning of this talk, towards present Indian healthcare policy. We want students to analyze and determine the intent to pass legislation on current healthcare programs and the repercussions of those. We want them to understand the historical development and the current functionality of the Indian Health Service. We have them examine the purposes and functions of specific reservation tribal-based health programs, community, urban Indian health programs, and the interplay between those and federal health programs. We also delineate major disease states, underlying causes of mortality and morbidity in natives, both past, present, and future. We want students to identify and define the nature of healthcare delivery programs in general, recommend solutions. So we have them think about these things in a very a creative way. And we strategize with them about determining their own path of service to serve the future directions of American Indian Alaska Native healthcare in this country. And they, I really, I think this is important, but I really want them to understand that traditional Indian medicine is currently used and exists concurrently with modern Western medicine. And again, they learn how to do a sensitive cultural belief, spiritual assessment, which is important. And they gain appreciation to, what are the current contributions from Indigenous folks to modern medicine and health, which especially for Native medical students, is important. We celebrate them at the end of the year with a blanket ceremony. Blankets are a traditional gift in a lot of Native cultures, and it shows honoring and respect, basically. So this is an important event for the School of Medicine. It's an important event for the Native students at the University of Washington School of Medicine. It's an important event for our university in general. It takes place at the Wethlaba Intellectual House, and this is a picture of it in the right lower corner. It's a longhouse, a student longhouse that's on upper campus at the University of Washington. So we start things out in a very traditional way here in this important circle that we gather in. We call on, as is traditionally appropriate, we call on mentors and family members to talk about the students rather than the students talking about themselves. Because again, for a lot of our communities, it's very uncomfortable to talk about our own accomplishments. We blanket them, and then we, laugh, cry, and eat. So the food is an important part of things too. All right. So what have we learned with 8 minutes left? So we've learned that there are multiple systemic barriers to healthcare delivery for Indigenous populations in this country. Okay. We've learned that Indigenous communities in this country experience exaggerated healthcare inequities. And we've also learned that an avenue for us as academic physicians to address these inequities is to really bolster a certain academic institution's Indigenous healthcare curriculum for interested students who are destined to work in these communities. All right. This is my email. Just let me know if you all need something. All right. I think we have a few minutes for questions.
Well, I want to say thank you again, Dr. Deen. Great historical perspective, but really excellent work in moving forward innovations. I think one common struggle for many schools is whether curriculum, clearly the curriculum needs to be informed and developed through the lens of Native American leaders. However, sometimes a school may not have Native American faculty to teach it. So would you say that everyone at your school who teaches the curriculum is Native American? And what do you recommend for schools who don't have the Native American identified faculty to teach it?
Yeah, so I forgot to mention that point because that's the sole reason why the Indian Health Pathway is successful, is because we leverage our own Native faculty. We have about 20 Native a little bit more than 20 Native faculty currently. We have more than 30 medical students, and really that's the only reason why this is successful. All that issues in Indian health class, it occurs in the evenings over 9 weeks. And all the lecturers are Indigenous. I would say that another tip is to employ a tribal liaison, whether this would be through your school, through your university, or specifically your medical school. We have 2 tribal liaisons here at the University of Washington School of Medicine, one for the School of Medicine in general, and then one who works very closely with me in the Indian Health Pathway. So that would be a means to kind of obviate the issues with not having enough Native faculty, is having someone who is an ally in charge of these programming with general assent that this is what you should be doing, but then working with the tribal liaison directly with community partners to try to get at the root of the problems.
Great, thank you for that. I just want to make sure that I have a second question, but I also want to afford everyone an opportunity because we talk all the time, right?
I know, yeah. Yesterday we ran out of time, so.
Anyone else would like to pose verbally? Just unmute yourself or in the chat box. Any questions or comments?
I would like to make a comment and a question, if you would. So my name is Abigail, and I'm a nurse educator, and I have a special interest and history of working with Indigenous nursing students. We just did a poster I did with two students for a leadership diversity conference on holistic American Indian Alaska Native nursing student support programs, how they promote student success to create the next generation of Indigenous nurses and Indigenous nurse leaders. And what I see as a barrier, what I struggle with, I think you addressed a bit previously, was, in nursing, we have about 130 nurses with terminal degrees, and many of those nurses aren't faculty in programs. So in introducing Indigenous components to the curricula, I'm wondering how we can be best served as allies to do this, because we need to create allies amongst the other students, amongst the faculty, and we're a little unsure how to accomplish that. Can you speak to that at all?
Yeah, and I have the perfect person for you to talk to about this for specifics. And I put my email in the chat.
Okay.
It's Dr. Healthmp4. She's a PhD nurse practitioner who works with us in our cardiology group. She's Alaska Native. So please email me and I'll hook you up with Emily. But yeah, in general, that's problematic. And I would say that you may have some folks who are content experts across your university in general. Say you have a couple people in nursing, a couple people in medicine, a couple people in public health, a couple people in pharmacy, say. We've started these conversations where we want to join in for all the allied health professional schools associated with the university to come up with a shared curriculum, to idea share, and come up with priorities. So that's something that you could possibly do if there's not the more ideal number of Indigenous faculty in a specific professional school. But Emily thought about this for her PhD thesis. So I'll hook you up with her for more kind of specific ideas, because it's important. Because nurses are arguably the most important folks in the hospital. So inarguably, that is. I'm sorry, I misspoke. But it's an important issue. So thank you for the question and comment.
Yes, thank you. The last comment I'll make, I was appreciating your stats there on the number of physicians, Indigenous physicians. At present, in the nursing represents, Indigenous nurses represent about 0.2% of the workforce. So we're even less represented in nursing than in medicine.
Yeah, it's a travesty. But yeah, I think Emily would be a wonderful resource for you, and I'll hook you up with her. Who else? I know we only have 1 minute.
Well, I had a question in the chat group, so I guess I'll just read it. You mentioned the two units, the allopathic and indigenous oriented in your medical school and how they intersect or cooperate. Could you please give us at least one, and hypothetical if necessary, substantive example of how this happened or could happen in the course of treating a medical condition?
Yes.
And I'm interested in sort of systems of healing more than all the administrative stuff you address. So
Right.
I'd appreciate this.
Right. Thank you. A specific patient example that I know of for sure. We were caring for an Indigenous patient when I was a resident who had terminal cancer. They did not want to follow primarily with an oncologist, but instead got their cancer treatment through a traditional healer. Naturally, the traditional healer, as comorbidities popped up, as the patient declined, needed to consult the oncologist, and then the oncologist naturally had questions regarding some of the treatments that the person was getting. So there was a very continual back and forth between those two providers, and all for the benefit of the patient, who was treated in a very culturally respectful way, and per their wishes. I think that it's hard in academic places to set things up systemically. So I think that community clinics, tribal clinics, urban health centers really are the model for these sorts of cooperative arrangements, because they may fund, again, a center or department or a division of traditional health that works alongside regular allopathic system. It's really not possible for an academic center to train traditional folks, because the timeline for traditional healing for a traditional healer may be decades and decades long, may take a lifetime. So it's not something that you can drill down to a certain curricula. So.
Can I quickly ask you one other question, Dr. Deen? So you shared your parents' ancestry, and I was wondering if you have, New Mexico is interesting in that 12% of the New Mexico population is of Native American identity, and 50% is of LHS plus, which I say is Latino, Latina, Latinx, Hispanic, of Spanish origin. How have you come across curriculums that look at the intersectional identities of both Indigenous history of Latin America and Native American history in the United States? And is that something that you could do a follow-up talk on? Or is there individuals that you're familiar with that can talk about the richness there?
I'll think about it and get back to you. But historically there were no land borders. So Indigenous folks in North America were Indigenous folks everywhere. So I mean, these borders are not, they're made up and false. So I would say the systems of care for Indigenous folks in this country are would be identical, and maybe just as fulfilling as those from Central America. I think Allison Kelleher. I think she's talked about this a little bit, and it kind of getting to the more kind of global kind of Indigenous health traditions and those sorts of things, really touching upon Indigenous folks in Southern North America and Central America and South America. So I think that she's done some work on this. So, but let me think about that more. I'll text you.
Excellent. So any final questions or comments by anyone on the call? Thank you, everyone. I know people are balancing attending today and managing their clinical and research and educational work. Anyone else?
Dr. Leo?
Yeah, I just put a link into the chat. I got on a little bit late, and I just wanted to at least put this out there for people to look at. It's an endowed scholarship, which I was involved with starting a couple years ago, and have gotten significant amount of donations to the point where we're able to give small grants to 2 or 3 students each semester coming to UNM from the Four Corners area. So if you have a chance, just take a look at it and at least consider it, and perhaps forward it to others who might be interested.
Yeah, it's great. Any help these pathway students can get. So thank you for that. All right, everyone. I want to say Nita Nitaki, thank you for the invitation, and thank you for your attention and wonderful comments and questions.
Thanks for your presentation. It was great.